Girl, stop it.
Well, you can adjust it if you want to hear that. You use this part. Yeah. So bring it close to right there. I'm so nervous. Doreen, I'm so nervous.
You did good, yes. She tell me when, right?
3, 2, 1, she'll say.
3, 2, 1.
Good afternoon, and welcome to our show, The More You Know Show, on KBBG FM 88.1. I'm your host today, Doreen Mingo, and this healthcare programming is made possible through a grant from the Guernsey Foundation. This month we are observing Stroke Awareness Month. My guests today are Tina Douglas, MSN RN, and the host of The More You Know Show, and Will Evans, RN, BA, BSN, Community Relations Coordinator at Unity Point Allen Hospital Inpatient Rehabilitation Program. Welcome, my guests.
Glad to be here.
Yes, I'm happy to have you also.
Thank you, Carol.
You're welcome. So today we're going to be talking about rehabilitative nursing, and it is one of the definite up and coming nursing specialty areas, and is being incorporated actually in all avenues of the hospital, but we do have a specialty program and a specialty unit. So can you guys, Tina, I'll start with you, besides the listeners knowing that you are the host of The More You Know Show, share with us a little bit about your nursing background and how you got into rehab nursing.
For my nursing background, I started many, many years ago as an LPN. I got my LPN from Hawkeye Tech then, now known as Hawkeye Community College. Then I went on and got my bachelor's degree from Graceland College in Independence, Missouri. Then I went to Allen and got the master's degree 10 years ago, and the master's degree is in nursing education. But I worked at Covenant for 23 years as a rehab nurse. So I am a rehab nurse to the bone. So I'm truly grounded in rehab, in all aspects of rehab. But I believe it was in '89 is when I started at Covenant on rehab, and at that time, Covenant had 3 wings of rehab nursing. You had the head injury, you had the spinal cord injury, and you also had the stroke unit, and then they had a 9-bed head injury unit. And the head injury unit was the unit that I started on just coming from out of school from getting my RN degree, my 2-year RN degree. So that was an associate's degree that I held at that time. So I had the 30-day, I was fortunate enough to have a real intense rehab orientation. I had 30 days of training. So I knew all the different, I knew how to take care of strokes, I knew how to take care of the spinal cord injuries, I already knew how to take care of the head injuries. So due to politics or whatever, all those units merged together. So now we're all on one unit. Of course, along with that came a lot of bickering because I was a head injury rehab nurse and the other nurses were stroke rehab nurses or spinal cord rehab nurses. So there was a lot of bickering because I only wanted to take care of the patients that I was familiar with, even though I had the orientation on all of them. It's just that I worked with them on a day-to-day basis, so I felt more comfortable. So it took a while. It took about 3 to 6 months for us to merge and really work together as one and being able to take care of the patient no matter what group that you were presented with, after that morning report. But I was fortunate enough to learn about all those patients, and along with that, I learned everyone else's job responsibilities too. Like if the secretary wasn't there, that's not a showstopper. We need to do what the secretary would do. Also learn how to do what the nurse aide did. So the nurse aide wasn't there, that shouldn't stop you either. You still have a job to perform. So I was fortunate in that way because it had changed so much over the years where you went from 30 days like I had down to 2 weeks, maybe a week. And that's just not enough for a specialty as far as I'm concerned. So
I think it's not enough for a brand new grad.
No. I don't know what it is now for the orientation.
Yeah.
I know there's more things because everything's computer and you need training for this, training for that, HIPAA and so forth. But just to have that 30 days intense rehab training is what I needed. And all the time I look at the other nurses and I would just think, wow, because they would work circles around me. I was just new, and I just couldn't wait to get to where they were. It took me about a year, a full year to get all your wits about you, where you could really handle the list, handle all, and know what you're talking about when you're doing teaching all the time, because rehab is about education.
Oh, yeah.
So it took about a year to have my own persona, my own personality about how I wanted to take care of my group of patients. And a lot of times it was a mixture. You get some stroke patients, you get some spinal cord injuries, and you get the head injuries, and all of them are challenging. And the most challenging of them all, I would say, be the head injury, because those patients are never the same.
Right.
These patients are patients that you can't reason with, you can't beg them to take the pill. If you take your pill, I'll let you watch an hour of TV, because they don't care, because most of them don't have that executive function, to make that decision. So
Right.
they're the most challenging, and I think the ones that are the most rewarding are the stroke patients who, you see the patients at their worst, they're not able to talk, they're not able to
Right.
use one side of the body, and if they get just a little movement in their hand, or able to utter out one word, we all rejoice.
Right.
And then the other ones that are the most difficult would be your spinal cord injuries, and it's just a joy to see them have just a little, minute movement in their finger,
Right.
where they had none.
Right.
We all
Right.
just rejoice. But we are very close as far as having rehab nursing as a culture. We were very close. We would all do the same thing. We were all accountable to the same thing. I mean, you wouldn't hear about one rehab nurse that did something odd or didn't turn a patient. Because if you didn't turn a patient, that
They'd
would,
break
yeah,
down
you
right
got to
away.
go.
Right.
That was you just didn't do that.
Right.
So it takes a special kind of nurse to be a rehab nurse, and you had to meet our standards, coming in, trying to, be a rehab nurse. You had to you just had to make it on all levels, or you weren't gonna make it, because we were so hard with our expectations of ourselves. So coming in, you had to be accepted, you had to really go with the flow, you had to keep up with us.
Right.
So I'm just glad to say that I had that background, and that has just stuck with me. That's who I am, as far as rehab nursing. I'm not working in any nursing capacity today other than being an Army nurse, but that has stuck with me, and it always will.
I was doing a little research today before I came for the show, just to better familiarize myself with rehab nursing. And one of the nurses who I was reading her speech that she had just given in front of the rehabilitation committee, and she said she'd worked in many areas of nurses, and we're all nurses, so we know we move around. But she'd worked in many areas of nursing, but on each unit she ever worked on, she found herself being a rehabilitation nurse first. So I like that you said it's really a part of you. It's who you are and what you do, what you bring to the table with all of your patients. Now I'm going to pivot, and I'm going to ask Will, who it's so nice to see him sitting here, because he is one of my former students, and now he's graduated and gone on and doing his own expert thing. But Will, just tell us a little bit about yourself. Tell us about your nursing background and how you got to the rehab unit.
Well, Doreen, yeah, we've known each other for a few years here.
Yes,
I am a
we have.
newer nurse. I don't have the years of experience, but more recent graduate. So I got a little bit of a different perspective on things, like you said, when nurses first coming out of school, and how
Right.
what they know, how much they need to learn. And there is a lot to learn in nursing,
Right.
and there are a lot of different areas.
Oh, yes.
So my background, I graduated in 2010 from nursing school, and in that time I worked in...
Has it been that
It
long
has,
already?
isn't that something?
Wow.
I know.
Time flies.
It does, and it just seems like there's been so much that's happened since then. But in that time, I worked in the intensive care unit for Allen Hospital and in the emergency department for Allen Hospital. In those areas, it was a very interesting perspective that I had there, because I see people when they first come to the hospital, when they're just extremely sick, very scared, they're in a very vulnerable position, and it's heartbreaking a lot of
Right,
times. And,
right.
But you don't know what happens to them. You
Right.
don't see the process there. Even when they go to the hospital, you don't always see that.
Right.
Then when I was in the intensive care unit, again, they're extremely sick. The families are scared. Everybody's scared. There's a lot of educating to do, and I love to educate.
Right.
I also teach for the college for clinicals,
Right.
so I
Right.
just got done with that. And so yeah, there's a lot of education. They have a lot of questions. Again, you can answer them the best you can, but you don't know what the full outcome's going to be, and you never see that. And sometimes you really are getting a bleak look at things, because
Right.
you don't know how well they improved. You might look at somebody that's had a stroke, and maybe the one side doesn't work, or both sides of their body,
Right.
they're flaccid, and they can't talk, and you think to yourself, this is so heartbreaking. It's horrible to see what's going on here. How could they ever get much function back? How can they get that back?
Right.
Then here about a year ago, I was offered a position for the rehab unit, and not as a rehab nurse, but what I do for them is I represent the units as a community relations coordinator, otherwise known as a clinical liaison. So what my position is to help coordinate for admissions for people to come into the rehab, help the unit grow. I help coordinate the therapy and the nursing together. I get to see a lot of the patients, and I work with the physician very closely. I get to see them in the critical condition when they're out on the hospital. I go and evaluate them, and I make a determination what is the potential for this person to progress? How much therapy can they tolerate? Because there's a lot of therapy involved with rehab.
That's right.
Mandatory is 3 hours. We
3
cannot
hours
go
a day.
1 minute less than 3 hours a day, and to be, in all honesty, we go quite a bit over. I mean,
That's
it's-
a comprehensive.
Yes.
it is, and this is multiple therapies, between maybe occupational therapy, physical therapy, and speech therapy, and whatever the patient needs. And it's minimum of 5 days a week, but oftentimes it's 6-7 days a week that we're doing this therapy.
Right.
And even though it says 3 hours, I see 4 hours, I see 4.5. There's a lot of therapy there. So,
Yeah,
it-
that is, it is a lot, and patients have to come with a lot of endurance to be able to come to the rehabilitation unit, because most places when you're in the hospital, nobody's asking you to do anything for 3 whole hours. So when you
Right.
come to the rehab unit, it's a change in focus, and sometimes patients are not used to that. We have a caller, so we're gonna go to that caller. Hello, caller, you're on the air.
Hi, this is Tish Jones.
Hello, Tish. Can you turn down your own radio, please?
Can I what?
Turn down your radio, please?
I don't have a radio.
Okay, all right, we're working on it. Okay, go ahead and ask your question, Tish.
Well, I'm not sure what the question really is anymore. I thought I was supposed to call at 2 o'clock.
Tish,
Yes.
honey, your show is next Tuesday.
What?
Your show is next Tuesday.
Sorry.
That's okay.
Okay. That shows you what happens with stroke.
Oh, Tish, we'll be glad to hear your story. Next week, the show is all yours, Tish.
Okay.
Okay.
Thank you
Thank
for
you so
calling.
much.
Okay, well, we're gonna pivot back to you. We were talking about how when patients come to the rehab unit and they are required to do 3 hours, and I don't have a background in rehabilitation nursing, but I have had the benefit of being a family member of a patient who's on the rehabilitation unit. Both my ex-husband, Sam, and my father, Mr. Hill, both have spent time in the rehabilitation unit. So I have an up-close and personal experience with what it takes to be in the rehab unit. And I can remember when Sam was there, at one point he couldn't move his legs at all. So everything that we had to do for him, or that had to be done with movement, we had to assist him to do that. And coming from being a very able-bodied man who was a workaholic, and to go to that was quite difficult for him. And so I have that experience with, he had an inpatient stay at the Mayo Clinics for 3 months. So to transition to being away from home, being in an unfamiliar setting, only seeing your family, a couple times a week, and then having to recover and learn how to walk again. It was quite a journey. And then to watch my father, who was an elderly gentleman in his 80s, whose health was declining, and he actually fell and broke a hip. And so he went to the Allen Hospital inpatient unit, and just to watch his recovery, and I'm telling you that as a family member, being able to watch 2 people that you genuinely care about go from where they start from to where they end up was just, it was just amazing to see what those rehab units could actually do for them. So I want to say thank you to people like you two who spent time helping families like mine. So next question that I want to ask you guys is, tell our listeners about what an actual stay is like for a family member from the nursing perspective. A lot of times listeners won't have a realistic understanding of what rehab nursing is unless they've been in it. So give them a little bit more detail on what it's like from the family and the patient perspective. And whichever one of you would like can start.
Well, I can address that or start with that a little bit. I'm actively there, and we have a lot of families there right now, and patients now. There's a lot of different, the experiences that our family members and patients can have, it can be very different. This therapy is for them, the program is for them, it's not our program, it's for them. So what we like to do is simulate their home environment as best we can. So if they can bring in, or if they have some of their own equipment, well, of course we want to work with that. Maybe it's their own toothbrush, their own hairbrush, whatever it is that they are going to be comfortable, including their own clothing. We're not going to put them in a hospital gown. On a rehab unit, we shouldn't be wearing a hospital gown. We should be wearing our own clothing, including shoes, comfortable clothes that you normally wear on a day-to-day basis. So these days can get very long, a lot of therapy. So the family members, it can get a little boring sometimes. So there's things up there for the families to do. We've got a community room that's got it's got one of the Wiis, so you can play, they can go in there and play Wii bowling. It's got a computer that they can go and spend some time on. We got vending machines that if they want to get themselves a snack without having to go downstairs.
Oh, that's nice.
They've got, we've got a lot of books, we've got games that they can play, watch TV, watch movies. So there's a lot of activities that they can do during the day. And for family, they can participate in therapy too. And oftentimes we ask them to, if they haven't been for a few days, especially toward the end, they'll come and participate in it. Because when they go home, they're not going to have a rehab nurse at home. They're not going to have a therapist at home. They're going to have a family member that is not a medical professional, and they need to be able to transition into living with them at home. So we do encourage them to stay if they can. We bring pets in there too.
I think
dogs
that's
and-
one of my funnest part is the pet therapy.
Isn't that great? Yeah, we have one of our staff members there. She's got a little dog named Sophie. She brings Sophie in quite a bit, and she's a tech on the floor, so she just has so much fun doing that. We have a gentleman, he comes and plays harp for our patients, and we have a recreational therapist. So in addition to that 3 hours of therapy a day, which I should mention, it's not all 3 hours in one time. So we don't say jump on the treadmill and go for 3 hours times. No. We do break that up into small sections through the day, but people do need rest. And but in addition to all of that, we have recreational therapy, and our rec therapist is very important for both the patient and the family. So they work with them, but from the nursing portion of it there, of course, the nursing is involved with patients and the family members a lot. So we're in there as nurses. We're helping the patients out with medications, their toileting, their daily tasks, a lot in between therapy and when therapy's in there too. So it's not, and then we're educating them. We're constantly educating. What does this med mean? What does it do? The disease process. You had a stroke. It was in this location. We do a lot of, we help that the physicians aren't in there 24 hours a day. The nursing is there 24 hours
That's
a day.
right.
Exactly.
Families aren't
That's right.
always there when the physician is there. We do like to have them come for team conferences, but we
Right.
don't have that every single day. We do have that weekly. So the opportunity for the family and the patient to learn is from their nurse a lot of times. So we spend a lot of times talking about the pathophysiology, what's going on, what's the disease process, where the stroke was located, what we can expect, what area of the body we can expect that's going to affect, what the different medications. Sometimes people are lethargic after a stroke's very tired, and we start them on a drug that's called Ritalin. Now, people will have heard of that's been used for their children, and they see, why are we starting somebody in a rehab on this? So we can explain to them that it also can help for stroke patients or certain patients to help wake them up and stimulate and get them to act, so they can wake up and respond a little bit better. And hopefully we can transition them off of that, but we're constantly talking to the families and patients, and they appreciate that because they don't know these things. And if they have to look it up on the internet, if they have to look these things up, we're not doing our job.
Right.
So we need to do that for them. We need to talk to them, be there to answer questions, to make them, so they're less scared.
Yeah. And that's another aspect that I really liked about both rehab units too, was that even as a nurse coming with a medical background, there were things that I did not understand. And just to be able to have someone who could sit down and answer questions. And I must say that everybody was good about that. The recreational therapist, the occupational therapist, the physical therapist, the nurses, everybody was really good about sitting down and talking and helping you to understand the processes that's going on.
But keep in mind also, you were reacting as a daughter and spouse.
Right, not as a
So,
nurse.
Right. And I'm gonna come at you a little bit different when I'm there, like you were, as a family member, but, just to add on to what you were talking about, Will, also, I just want the listeners to know that when you come from another hospital, it seems like the education needs to start right on that admission, especially when the patient is accompanied by the family, whether it's from Iowa City or wherever. Because Iowa City, if you've had a stroke or had an aneurysm, you're going to Iowa City first. Iowa City is the patient's feeling, the family's feeling, they say, save the loved one's life, okay. So you're in intensive care for so many days, you have to go to a medical floor before you're discharged to come to Covenant or Allen or wherever you need to be. So, you know, I don't know what it is about Iowa City, it just seems like people just don't say anything to the people in Iowa City. You know, they're so grateful that they, you know, they were able to react and, you know,
Right.
save the loved one's life or whatever, but they don't talk to them in Iowa City about the things that they need to find out about the patients. So as soon as you get them, it's education as soon as they get the door, because they're so busy telling you they haven't had a bath for 30 days. Okay, did you tell them that in Iowa City they didn't have a bath for 30 days? So what day, how often do they get a bath here? You know, they're coming at you, you can't even get the patient in the door, they're asking you all these questions. No, first we need to get, you know, calm down, you know, I know he needs a bath or whatever, I can see that, you know, hair matted, you know, got some red sores going on, whatever, you know, from however they had to lay, but this is how we do things here. So it's education from the time you receive them, because it's a transition from one hospital to another, and it's a lot of anxiety. It's a lot of anxiety when you have someone, like Doreen said, someone who you know that was a workaholic, or someone that you know who was healthy and independent, and now they've had a stroke. They're not able to talk, they're not able to move, they're not able to function on their own. So yes, you have some concerns there. But, you know, you just have to get your rapport, get that rapport, make sure they stay calm while you're trying to do the admission, and let them know this is what we do, you know. This is my job, you know, this is what we're trained to do. So many times you'll have patients, families in the rehab setting that really don't know what to do, but they're there watching you,
Right.
you know, in a critical way. But you don't know what I'm supposed to do, so let me help you get past that, you know, the anxiety that you're having about, am I doing the right thing for your loved one? Because this is how we do it here. So, you know, like I said, it's education, teaching all the time, not only in just a rehab setting, but, you know, it's more so in a rehab setting, but it's with any hospital stay, so that you just stop that, you know, nip it right there in the bud, transitioning from one big hospital like the University of Iowa coming to Waterloo, Covenant Medical Center, or, you know, Unity Point on a rehab. You know, we have rehab services. Rehab was not available in Iowa City, okay, now your loved one is able to, you know, they're medically stable enough to be put in the rehab unit, whichever one you decided to go to, and this is how we're gonna help your mother, father, son, daughter, whoever, on this floor.
Right.
But, you know, you got to let them know, this is how this works.
Right.
No, there's not a shower every day. Usually you get a bath 2 or 3 times a week, however it's set up at your institution. And they can have a bath every day if you are willing to, you know, participate in those cares. That's how we set it up, you know. If you're able to help, you know, make sure that gets done. Otherwise, you know, our policy is 2 times a week, and would your husband or spouse or whoever the loved one is, would they like the bath in the morning or in the evening, you know, work with me, so we'll, you know, see what works best. If they prefer it in the evening, they at home before, you know, they had a stroke or whatever, they usually took their shower in the evening, okay, we'll do the shower in the evening. You know.
Tell me a little bit, ladies and gentlemen, tell me a little bit about the process in rehabilitative nursing, where you teach both the patient and the family about how to transition into the level of care that is currently needed now. For instance, I can remember when Sam called me and said he got a pass for this weekend, and he was going to be able to come out, and I, you know, had some nursing background, so I know pivot, turn, move, but I still worried, you know, okay, which vehicle do I take, and how do I ensure that he makes it from this pivot is good from the chair to the car, and I know the fears that I had having a medical background, even though I knew that I would make it through. What's the process, how do you teach family members about how to begin?
That's where therapy comes into play. That's how come it's important. Like Will said, they invite you to attend therapy, especially occupational therapy, that's addressing the stuff, and physical therapy, that they're gonna help you. You shouldn't took him without someone showing you how to physically transfer him, whether you have a nursing background or not, that doesn't matter. To transfer him safely, how he's been taught to transfer while he's in the hospital, he's
Yes.
the same.
And we
So
did
it's
do
his
that, but
system.
I'm just wondering about, does it begin at a certain week that family members begin to learn these things? I'm just curious about how do you transition, because I know a lot of family members are trying to be strong for their loved one, so they don't always show fear. What's the process that you begin to
Well,
bring these two
sometimes
together?
you can't engage family, sometimes it's hard to engage family because they sort of stand back, like,
Uh-huh,
just like Will said, we don't go home with you.
right,
So these are the things that you need to learn, but sometimes those families won't come around. They'll get their pass, they'll pull up to the carport, you put the patient in, and you'll say, okay, you're gonna transfer? No, you can't, that's your job. Okay, well, we don't go home with you, so I just wanna show you how to get them safely in the car, and they
yeah.
will not.
Yeah.
So, you know, you can always offer,
right,
because you're doing your job, by
Right.
providing the education. Now, it's up to them, you know, if they wanna, you know, take it in or not, but you always need to keep doing your job.
Right.
Sometimes they're not ready, sometimes they're never ready, sometimes that's not the right family member, sometimes it needs to be a stronger son or the
Right.
father to kind of
Right.
pick the patient up. So, you know, so the time is any time, you know, to teach them, but they have to be willing to accept and receive what you're teaching them. And a lot of times, they're gonna get that from physical therapy. That's the
Right.
best teaching. Physical therapy, you can come out to the car.
yes.
I'm gonna, you know, show you how to get your husband in, because there's one thing to transfer from the mat to the wheelchair, than from the
Right.
wheelchair to the car.
Yeah, it's totally different. Yeah.
Yeah.
Anything you want to add, Will?
Well, we do assess, we spend a lot of time assessing both the patient and the family and their home environments too. In going and accepting a patient for rehab, one of the questions that I have is about their home. You know, what type of, do they have steps getting into their house? What type of, is their toilet raised? Is their bed raised?
Right.
What type of flooring do they have? There's a lot of questions we have there, but also we're assessing the family members too, and how much are they willing to help someone, and how much do they know? There's so much information when they're, especially like you were talking about in down in Iowa City. There's so much information. They're scared. They're sick. Some of it they've heard and they don't remember hearing it.
Right.
They come back.
Information overload
It
sometimes.
is, and we have to reinforce that, but we're, right from the day one, it's a team approach there, not just between nursing and therapy. We also have social workers, and the social workers really start working with the families a lot. How much can this family handle? Is this too early for the
Right.
family to handle
Right.
that? Is this not the person we should be talking to? Should we be talking to someone else? Who's the right person to talk to? And sometimes that's what we need to find out. It's not that we won't talk to all of them, we will.
Right.
But which one is the one that's gonna be stepping up? And how do we approach this early on, so we just don't throw it at them and say, this is a weekend pass, you get to go home this
Yeah.
weekend.
Right.
Let's call them up and have them
Both,
pick you up.
both parties have to be ready. The
They all have to
patient
be ready, yes.
and the patient family has to be
Definitely.
ready.
Mhm.
And with that, you still need some support when you get there.
Right.
Yeah.
Because that patient's gonna be tired, even though their endurance is at where they can do the 3 hours of rehab, it's a different setting out of the hospital. Because most time you have a report, there's a report that they have to fill out how things went at home and when they were tired.
Right. I can remember, you know, there's so many little things that you just don't think about, and I can remember them asking for my dad if he needed a hospital bed. And my mom said, well, that would be good. And I'm like, well, you know, Mom, I think he can do it. I think he can do it. But she was worried about him being able to sit up in the bed, you know, because
Yes.
in the hospital you can grab the side rails, or if you have a trapeze above you can grab that. But at home, that bed is a little flatter and
Right.
it don't lift you up.
Right.
So you gotta have those good core muscles. All right, we're going to pause for a moment to take our break. Sorry.
Now,
Was I supposed to read that before or
you
after?
can always come up with an excuse for not visiting longtermcare.gov.
I was wondering if I read the thing before or after.
Ooh,
I'm like, good Lord, my phone is just beeping,
perfectly
beeping, beeping.
understandable. Since going to longtermcare.gov means you actually acknowledge that one day you will be,
You read the back.
dare we say it, home.
Come on.
Hey, do you see any cold sweet on this face? I don't.
And 70% of older Americans will need some form of long-term care services as they
She
age.
called it
If you're
215, my
50
God,
plus,
what are we talking
time to
about?
create
15
your
minutes
strategy
without?
for aging so you can stay
She had a
sharp.
stroke?
Yeah.
Well, you know, 50 is the new 30.
Sure.
Oh, okay. That cracked me up. She said, I
Long-term care.gov
really
makes it
don't have a
easier to
question.
figure out where you want to live, who will care for you, and the newest ways to cover the
It's
cost.
great to hear
She's
from
not
long-term
so
care,
proud.
especially because it
Find
gets
your
so
own path forward.
yesterday, I had tears
Hey,
with one of our
Isn't
patients.
that a new gray hair?
Where?
Leave.
we are back. This month we are observing Stroke Awareness Month, and we're here today on the More You Know show. My guests today are Tina Douglas, MSN RN, and Will Evans, RN, BA, BSN, Community Relations Coordinator from Allen Hospital Inpatient Rehabilitation Unit. And we are coming back. We're talking about stroke this month, and we were just finishing up talking about some of the hard work it takes and some of the things that you really don't think about when your loved one is transferring from the hospital setting to the home setting. You know, I know that as a family member, everything was made so easy, so convenient in the hospital. And then when you get home, you gotta reevaluate your home setting and change stuff and move stuff around. I know one of the things that I noticed is that all of our furniture was too soft. It was the kind of furniture that you sat down and sank in and got cozy. And when Sam came home, he needed a little more sturdier furniture that didn't let you sink as low and get it, you know, we wanted to melt into the couch then. And as we're getting older now, and when he was sickly, you wanted to be able to have a little firmer so that he could actually push himself up better. So there are just, and I say that to say there are so many things that family members have to think of, and thank God that they don't have to come up with that on their own, because we have people like you and Tina who are helping us to think about that stuff and plan ahead and just share. I'm going to open it up right now and have you tell us a little bit about anything that you would like for family members maybe who are in our listening audience who maybe have some questions or concerns. Where should they turn to get their question answered if they don't have an inpatient, program right now?
Well, that's a great question too. So sometimes it's hard to find information on where you should turn, who you should talk to. Of course, you always go back to your physician, talk to your physician. You have questions about anything about your health. You have any recommendations that you need done, ask your physician, what can I do? Where can I find more information? Of course, there's agencies out there like Northeast Iowa Area Agency on Aging that has just a wealth of knowledge. But stop at your hospital, stop at Allen Hospital or Covenant, wherever you're comfortable with going, and talk to them, talk to the hospital at the information desk, ask them what type of programs do you have. A lot of us hear commercials on the radio or see TV about rehabilitation through skilled nursing homes or through nursing environments. Now there is a difference, and I think that's a very important thing to point out, that there is a huge difference between rehabilitation out of a hospital setting. In a hospital setting, it is an intensive therapy, and our primary goal is to get you home and return you not to your house, but to the community.
Right.
We want you to get back to what your previous life was. If you were a farmer, we want you to farm.
Right.
If you went on walks every day, we want you to go on walks. If you will go to church every week or every day, we want you back in church. And we're going to test those, and we're going to try those, and we're going to work with you several hours a day to get you there as quickly as possible while we still have medical support. At the nursing home rehabilitations are great for some people, but not for everybody. So it is a great time to evaluate, do I need more intensive therapy, or is this something that I need for a longer period of time at less intensity? So it's information, ask questions, ask your primary care provider, ask nurses.
And there's so many resources that are available, just if you know how to access them right in our communities.
Right.
And again, I just want to touch on, you're talking about outpatient, the different rehab services, the hospital versus the nursing home, and you know that Parkview just moved over there by the hospital, by the college.
By the college,
Northcrest,
that's our neighbor.
and they have rehab now, and it just depends on
And
what
I
you
just
need.
want to point out that Northcrest is absolutely beautiful.
I know.
So listeners, if you have not had the opportunity
Went
to
the open
visit our
house.
newest neighbor, the Northcrest Senior Center, Senior and Rehabilitation Center, that's located just behind the Hy-Vee stores, right next to me at Allen College. Come on over and visit. You missed the official open house, but I'm sure they're welcome visitors. It's a beautiful, beautiful place for your loved ones to go to either have some assisted living, to have some nursing care placement, or to have some rehabilitations
rehab.
before they come
It's a
home.
beautiful place.
Which is
It's a
what we're
beautiful
talking about,
place.
because like I said, it depends on your age, depends on what you need. Sometimes all you need is that transition,
Right.
like what Northcrest has to offer. The transition to get you back to your home.
Right.
Not saying, and then you just transition back into the community. It just depends on what you need, so.
Right. And I
we
know
have
sometimes.
places like that in place here.
Yeah, and that's a really nice one. And it's close to home. So the fact that it's come over by Allen College has allowed family members who live on the east side, or what's officially the north side of town, to be able to be closer and not have to drive so far away to get to some of the rehab places that we used to go to. So I just encourage you guys to look at North Crest. I wanted
And
to.
they have state-of-the-art equipment, I must say,
Yes, they do.
for the rehab.
I haven't gotten a chance to tour. I've seen it from the outside. It just looks gorgeous. I didn't realize it was open yet. So I'm
It's
gonna have to
beautiful
stop by.
outside and in. I think it's about a week ago that they had the
I think
open
they moved in
house.
on a Monday.
Yeah. Last
Just
Monday
moved
they
in last
moved in,
Monday,
and the
yes.
open house was the weekend prior.
Yes.
Yeah, it was really, really nice. And I was happy to say that when I walked over, because I didn't have far to go. But when I went over, there were lots of community members who were visiting and enjoying just checking out the unit. And it's beautiful outside and in. And it has some beautiful scenery back there. I know the patients will get to watch some of those deers that are always out there, and rabbits and everything. I've even saw deer in the parking lot of the college
Yes.
at night. So I know they will be coming up to those residents' windows. I wanted to ask you guys, rehab can be challenging for patients. As we talked about, family members don't often understand the difficulty or the intense therapy that it takes in just being able to get a family member just to be able to lift their leg and hold it off the bed for a second or two. Or even sometimes just to be able to move their toes or move their feet, And it's really sometimes scary, especially with a brain or spinal cord injury, because you don't know what that progress will be. They tell you, wait 6 months, wait a year, and you might be able to tell. But you just don't know, and so in the beginning it's really fearful. What are some of the challenges that you have encountered that you'd like to share? And then share with us the outcome, because we want to let people know that, sometimes the prognosis may look bleak, but, sometimes it's great in the end. It really is great in the end.
It is, and you don't always have a crystal ball to, like you said, you don't know 6 months for a year out.
Right.
And when you're evaluating a patient and you're talking to the family and they're asking you, well, what can I expect?
Right.
And you don't really have an answer for that at that time. And you might even think to yourself, this is bleak. Yeah, you might be looking at that way. And we have had patients on our floor, stroke patients in particular too, that have gotten up there and they've been flaccid on both sides. You've maybe use a call light that you have to blow into because you can't even move your finger or a hand to do anything. And even therapy will be challenged, and the nursing will be challenged. How are we going to get 3 hours of therapy with this patient? How are we going to start? Because it's day one. Day one is 3 hours.
Right.
So how are we going to do that? And the couple of patients that I'm talking about, we have one right now on our floor that yesterday I was just on our break. I was telling Doreen that he actually was starting to tear up yesterday as her husband rolled her by and stopped to talk to us, and she looks amazing. I haven't seen her for about a week. And just a week ago, I helped her up to the bathroom. Took 3 of us people, and now she looks so much better. She's able to move. She's responding to us, purposeful movement. This is great. She's starting to talk, and I mean the progress she's made in just 1 week. And we've had other patients that like I said, flaccid, that have had to use a call light that you had to blow into, and they're there for quite a long time. But that's the start of their rehab. But it does continue to go. Then the progress that this one patient has made, he comes back and visits once in a while. He came back to show us, look at what I can do. Stands up on his own and walks. And we start that process off for them. We help them, and it's so great to see it. But it brings tears to your eyes sometimes just to see how well somebody can do, especially when you do think that it's
Something so small. That is not small. Those are things we take for granted, things that we do every day.
Yes.
Right.
Now, to use that ability to do it
Right.
makes you take a second look.
Right, and having to relearn simple things.
Right.
Simple things that you never even put any thought into doing, like, turning around to pick up a towel, or turning around to grab your pants to put them on, and all of a sudden you can't do that.
Taking a sip of water.
Right. It's challenging. I can remember when Sam was first sick, and of course I asked 50,000 questions. Having a medical background, I think that's sometimes worse. And people would say to me, how's he doing, how long? I can remember one friend said, well, how long before he'll walk again? And he would ask me that all the time, and I always would look in his eyes and say, I don't know. I don't know if he will. In my mind as a nurse, I wanted to prepare for the worst, prepare the house for if he never does. walk again, you know, so that he's comfortable, so that everything is in reach and in reason and what he needs. But you still keep that hope that one day it will change. So I know family members struggle with that, and sometimes family members need additional assistance in addition to the loved one. So are there programs or support
I
groups
think
that you
what
know
really
of?
helps is, you have to accept what's happening.
Right,
You have to
Right.
accept where,
right,
you know, meet what's ever going on where it's at.
right,
And that helps a lot. So much, like with the spinal cord injuries, I know we're talking about stroke, but with spinal cord injuries, it was so hard, like, to teach the family anything, because they're like, oh, he's gonna walk.
yeah,
Okay, but right now, this is where we're at. Right now, if you just meet me right here, this is what we're dealing with right now. It's just so hard. Like, I believe he's gonna walk out of here, but right now, they're not walking, so. But like I said, you have to wait till they're receptive. You know, when I started nursing school years ago, they said, you know, education begins on day one. It doesn't begin on day one. You can have the knowledge and stuff, but it might not be received. You can always give it on day one, but it might not be received. That's how come we have to keep doing it over and over and over again. That's why we're here in the studio today talking about this. We are talking the whole month about strokes, because it takes more than just 1 hour to talk about strokes, and the services that are provided, and the nursing that goes with it, and all the other modalities and aspects that go along with having a stroke, and the resources that are available, and the services that are available, that the listeners might not know. Some people might think they're alone. Well, you know, my husband had a stroke and nobody helped me do anything. There might still be some rehab that will benefit.
that's right. And you know, rehab does come to your home, for the ladies, for the listening audience. There are physical therapists, occupational therapists, speech therapists that will come into your home when you transition home and work with you. So you need to work with your primary care physician to figure out if you are qualified for that. I know from time to time I'll still have rehab come and work with my dad, you know, because he'll get strong, he'll do well, and then rehab goes away, he slowly stops doing his exercises, and then he gets a little weaker again, and then we'll get him signed up again. So you can benefit from rehab services coming into your home, the nurse, the aide, the homemaker, the physical therapist, the occupational therapist, all available to you. If
And
you're not
speech.
listening on, and speech, yes, and speech.
Speech is really important. When you've had a stroke, the speech is not there.
Yeah, yeah.
Or your speech is not the same, or
Right.
it also has to play with how well you're eating, you know,
That's right.
how you're swallowing your food, are you choking, you know?
Right, right.
And cognition,
Yes.
speech therapists will work
That's
with
right.
that. But especially with strokes and a lot of different things, but strokes in particular, just the hospitalization, the acute state doesn't end right at the acute state. You still follow up with your doctors, so if
Right.
you go to the hospital. Rehab's the same way. You start off with early and intensive therapy, so you get
Right.
as much therapy as possible on an intensive level to get you to a point either that you can get home, which is what we prefer, or that you can step the therapy down a little bit and move into the senior centers or the healthcare centers, nursing centers, the skilled nursing centers, get some therapy there, then go home and get more, or just straight from the rehab unit, go home and then have the home therapy come in. So just because you left the hospital doesn't mean your therapy is done, doesn't mean your
That's right.
treatments are done.
That's
There's
right.
still a lot of treatment that can be had and that you qualify for, and those benefits are out there they're for you, they're for our patients. Yeah, we do whatever we can to get our patients home and get them back to their lives and with their family, and I mean,
Yeah.
we're very vested in that. And nursing is a huge advocate for patients.
Oh, yeah,
Yeah,
that's what we do.
That
We
is
take
what we
care
do.
of
We
patients.
fight.
And you don't need to be a nurse in order to have a family member be discharged to home.
Right.
By the way, well, dad can't come home because
Right.
there's nobody to take care of him.
Right. We
But
can
they're
teach you.
thinking you need to be a nurse. You don't need to be a nurse.
Mhm.
You need to be a willing family giver. I know
That's
that.
right.
I know that from
That's
my
right.
mom, that, you know, helping
That's
take care of
right.
my father at home. She did take care of him at home. She's not a nurse, but she
Yeah, you learn.
learned.
You learn. There are many examples.
She
in
do
our
everything
community.
that I
You
could
learn.
do,
That's
but I
right, you
do
learn.
That's right.
And you know what? And you don't have to be the biggest person. The person that you're taking care of can be bigger than you, but there are techniques and strategies that you can learn
That's
to
right.
actually move and
Yeah.
help and handle
Yes.
that person
do it
and do
safely,
well.
so
Yeah,
that you're
do it
protecting
safely
the
and do
patient
well.
And
And
your
yourself.
loved one and you.
Yeah. I know that, and Tina, you kind of alluded to this earlier, that there are a lot of times that patients go through other challenges just besides the physical. You know, we know that rehab works on the physical. what do we do for patients to ensure that their emotional, social, and spiritual coping or support is taken care of?
Well, in the hospital, they always have like chaplain, Covenant has a chaplain, Allen has a chaplain. That's part of the assessment for the family, knowing the family dynamics. You know,
Right.
what do you use? Do you have any spiritual
Right.
guidance, anybody that you look up to? You need to know that family modality, you know, to deal with that. But for patients who cannot talk, like the stroke patient, you need to deal with the family
Yes.
and see, you know,
Yes.
what is your support?
Right,
Have you ever reached out? Have you called on the Lord, you know?
right.
Do you have anything in place? Because everybody needs help, like I said.
A higher power.
You know, you go from your husband, he takes care of everything, you know, he's my all in all, you know,
Right.
I'm retired, I don't have to do anything, you know, and my husband takes care of it now, I don't know what to do. Because you don't want your house to fall apart, you don't want the patient to
Right.
become better, and all of a sudden you don't have a home to go to because you weren't able to handle the bills.
Right.
You have to have some outside support, and that's when you're using chaplain, your social worker, that's where they come into play. There's services that are available, places like that. I just want to keep in mind too, when you do have a stroke, whatever your personality is, that personality is more exaggerated.
Oh, yes.
If you were type A personality, it's more exaggerated.
For brain injured and spinal cord.
All of them, it's
Yeah.
just more exaggerated, you know, like when people get older, well, mother makes me so mad, you know, okay, she was like that before, what you're seeing is just more exaggerated. She's always been
It's
like
worse.
that, but now it's just to where it's just right in your face, you know, but that was her personality before, it's just more exaggerated due to the, you know, disease processes going on.
And sometimes Tina, it's beyond worse. Sometimes it's a change. Do you
Yes.
think it's
Yes.
a total change? I know I've dealt with some brain and spinal cord injury patients who actually just get mean.
Well,
They're angry.
the head injury patients aren't the same.
Right. Right.
They go through a process too, especially for brain injuries, that as they're healing, they go through different stages. And there's a scale, a scoring tool
Right.
that they use to score that. And there's a stage there that is very agitated
Yes.
and inappropriate stage.
And they might
it's
get
not
stuck in
something-
that.
Yeah, and they can't control that. It's not, yeah,
Right.
sometimes they can't get past that. But hopefully with time, they will get past that stage, and with a lot of rehab and a lot of work, that they can improve that.
So the best thing to do, and I've said it on all my shows, the family, who's ever taking care of that patient, you need to make sure you have everything available to you that you know about what's going on.
Mhm.
Because that cuts out from you know, respite care, that's not gonna be a respite care. Because you get fed up with them, you don't understand.
Right.
Well, why is he hitting at me? Because this is where he's stuck as being head injury. You know, they weren't doing that before. Because you can't bargain with them. If you don't hit me, you know, I'll let you,
Right.
there's no
I don't
reasoning
understand
at this
that.
point.
Yeah.
You know, that's a phase that you hope that they transition through. Of course, it's medicine, they have to work through that process. But you have to know everything that you can possibly know about what the disease, about the stroke, and then you'll learn by spending time with the patient how that is affecting him.
Right. I know I worked with a nurse at the college, and she was a rehab nurse for a long, long time before she came to education. And I always remember what she said, and she said, I love rehab from the bottom of my heart, and the reason is because it's one of the few places in the hospital where you get to see people make miraculous changes.
And it is
And I have to,
miraculous.
yeah, it
And
is
it's so
miraculous.
rewarding.
It
People
is
like,
so
how can you
rewarding.
be a rehab nurse? I can't
Yeah.
stand coming out to, you know, work with those rehab patients
Right.
because there's rewards out there.
There really is, you know, I can just look at from, you know, when Dad came home and he was real weak and we had to stand right beside him to help him walk, you know, from his room to the bed. Or when Sam got out of surgery and he couldn't lift his own leg off the bed and now he can run down the street if he wants to, you know, it is just miraculous to see where patients can go to, where they come from and where they can go to. And so I just want all the people in our listening audience to know that if you are currently facing some health challenges from a stroke, a brain injury, a spinal cord injury, you know, don't give up hope. You know where you are right now today, but if you put the work in, you never know where you might be in 6 months to a year. Because of some of those areas that are injured, sometimes it takes a longer time for them to heal themselves, for those myelin sheaths to come back, for cells to be regenerated, so that you get better, but you will. We see the miraculous stories on the news of people who were injured and who vowed that they would walk again, and they find the means to do that. So what we want to tell you is keep hope alive. Don't give up. There is always a possibility that you can achieve and succeed or supersede whatever your rehabilitative goal was.
And it does take time. It takes time to heal. It's gonna be a while. It's gonna be a
Yeah.
process.
Yes,
You're not gonna just,
yeah,
usually just a miraculous recovery from a stroke within 2 or 3 months.
right.
The process is slow. It might be a year to where you said, well, the
Yeah.
patient comes in, he said, look what I can do now, you know.
That's
They're
right.
dressing their own clothes, you know, they're doing their own thing, you know, that's the
Right.
patient.
Right.
You know, their hair is made up, or whatever's going on, they found their self again, so.
Right, and they have to learn how to celebrate the small successes. Because, you know, maybe you couldn't put your shirt on before. Now maybe you can put it on. Maybe you still can't button it yourself, but you can get it on. You know, I was so amazed at all of
It's
the
baby
different
steps.
baby steps. And you know, you're not gonna be in the hospital in rehab for 6 months. You
No,
know,
no.
that is just not unusual
Right.
for you to do that. So
Well, nowadays
patients-
it is.
Yeah.
Back in the day.
You can,
before-
yeah.
Before,
Yeah.
the
It used to be,
and everything,
yeah. Well,
the
we could be
spinal
on
cord
the-
injuries would stay at least 3
Yeah.
to 6 months.
Yeah, well, back in the day, we could stay on the
Yes.
mental health
Yes.
unit for